Hello and welcome to Health Professional Radio. I'm your host, Neal Howard. Our guest in studio today is returning to talk with us about ambulatory detox and addiction medicine as a whole. Dr. Indra Cidambi, recognized nationally and internationally as an expert and pioneer in the field of addiction medicine. She founded the Center for Network Therapy, New Jersey's first state-licensed ambulatory detoxification care and treatment facility, and she's currently serving as that facility's medical director. She's here to talk with us about a new drug-delivering implant that's been developed. How are you doing today, Dr. Cidambi?
Thank you. I'm doing good, Neal.
Thank you.
And I'm here with you to talk about the new implantable Suboxone that's, waiting for an approval.
Yes, absolutely. Now, it has already been through the testing phases. It's waiting just for approval now. Talk about how this new drug delivering implant differs from normal Suboxone addiction treatment.
Yeah, in order to go into this Probofine, which is an implantable rod-shaped 4 rods that needed to be placed inserted subdermally in the upper arm of a patient who suffers from opioid dependence.
Mm-hmm.
So this is mainly for the maintenance treatment. In order to understand this implant, I would like to kind of take you back to explain a little bit about buprenorphine. This buprenorphine is a Suboxone, Subutex, which are taken under the tongue, and this was developed so that it can serve as a safer alternative to methadone, which was the traditional way of, people going to methadone clinic, and which is a full agonist at the new receptor, opioid receptor. So that kind of took over by buprenorphine. And when buprenorphine came into the market, this is the 3 things that we were looking into. Buprenorphine gives a ceiling effect for respiratory depression at a moderate dose. So that means it's an impossibility to overdose on buprenorphine. That was one expectation. The second one was there will be no physical dependence to buprenorphine, and they will have very mild withdrawal symptoms. There will be physical dependence to buprenorphine that was associated with mild withdrawal symptoms, even though they get addicted to buprenorphine itself. And the third one will be limited attractiveness as a drug of abuse relative to methadone, because methadone is a full agonist and buprenorphine is a partial agonist antagonist. So it you don't start abusing the medication. Then, buprenorphine displaces a full agonist at the receptor in the brain. There is a reduction in receptor activation, and therefore it can produce withdrawal effects. That's, what I mean by that is, suddenly, if somebody is taking opiate and then they take buprenorphine, there will be a sudden severe symptoms of withdrawal, and when they use buprenorphine. So that kind of makes them want to wait before they take buprenorphine. Okay. Despite all these things, you did see that there's been an illicit drug market for buprenorphine. And there is a diversion, abuse, and misuse, and also accidental poisoning of small children with buprenorphine, and there was death among young children. That's why, having said this, kind of sets the stage up for us to understand why we are in Suboxone, Subutex, the buprenorphine is already in the market, methadone is available. Why are we looking at something different, right? So this kind of explains. Now, they were looking at a depot injection or an implant product so that it will kind of address the diversion, abuse potential, and the death among the young children.
Let's talk a bit. Let's talk a bit about the opioid addiction epidemic as a whole in order to understand how this brand new drug delivering implant will benefit addicts going forward.
Yeah, you see this epidemic, national opioid overdose epidemic is what we are looking at. There's a total overdose death of 47,055 lethal drug overdoses in 2014. That's the leading cause of accident, of death right now after the accidental deaths in the U.S. now. This has been a driving epidemic. And you see opioid overdose total 39,400, just related to overdose and death from heroin.
Yes.
And the prescription pills in 2014. So you see the trend of really increase in this overdose and death for both prescription pills and the heroin use right now.
Do you think that our culture of continued levels of high stress add to the snowballing effect of this epidemic? Because it's not like opioids just came on the scene, but it seems though there's this explosion.
No, that's not just the stress alone. In the past, what happened was there was a moment where, they were looking at pain as a fifth vital sign. Meaning they said any patient who comes into the doctor's office, you need to ask about pain as if you do the other vital signs like blood pressure, pulse, and temperature. And then they said also look at the heart rate and then ask for pain as a fifth vital sign. Once that came into practice, there has been a raise in writing prescription for pain. If patients were talking about pain and the doctors were prescribing, and you see the raise in prescription pills. And so once that happened, and those who have the predisposition to become an addict, they started misusing these prescription pills, and eventually they've been dropped out of treatment by the specialist. And then these patients were suffering from withdrawal symptoms. They didn't know where to turn to, and they went to the market and bought pills by paying $30, $40 per pill. And that became very expensive for them, and they had to turn to less expensive method of keeping their withdrawal, under control. So they turned into heroin. And you see that there's a trend that we have been seeing over these past couple of years, and it's been increasing. And so many young people have lost their life for this opioid addiction.
Do you see
it's absolutely out of control right now?
Do you see an absolutely huge reduction in the rate of relapse using this new method of opioid addiction treatment?
The new method has not yet, been in the market, and I cannot say whether that's going to make that is the answer or not, because as I told you, from methadone to buprenorphine, and we do benefit with buprenorphine when people take buprenorphine the way they are supposed to, meaning they take the medication, they get the therapy, and they're going to 12-step programs, and if they are maintaining with the sobriety lifestyle, it does help. So, the reason why we are even looking at the new medication is because of the three things. We don't want diversion, we don't want people abusing, we don't want misuse of medication, and we didn't want the young children to die. So those are the reasons why, the probofine, which is the implant, has been studied right now. That's trying to get the, footstep into the treating arena. But then we don't know whether this is an answer. As I said, there are pros and cons with this probofine. As I said, the major concern that we have, there are concerns, and let me tell you, implantable contraception that they have been using in the United States had lots of problems, like pain at the site of the implantation, and also infection, numbness, and this is all about the contraceptive pill that the implant that they used in the past, along with the bleeding and hematoma. And the worst thing with the contraceptive implants were that it affected the ulnar or the medial cutaneous nerve and damaged that. It led to the permanent disability. So that's why most of them are gone, and there is only one implantable contraceptive still in the market right now. So looking at that picture, we wanted to see probofine is also an implantable. So there is a concern about that. But that's only a minor concern, But then what is the most important thing for us to pay attention to is that these implantable ones are not conducive for the current prescribers. What do I mean by that is that if you see the buprenorphine that's being prescribed, 32% of the prescriptions for buprenorphine, naloxone, sublingual tablets, or the pills have been written by general practitioners, family medicine practitioner, doctor of osteopathy. While some of these guys are prepared to do some minor surgical procedure, while others are not, because the implant itself is a minor surgical procedure. Okay.
Okay.
So 22% of the Suboxone prescriptions were written by psychiatrists. These professions are not trained to do a minor surgical procedure. But even that's not a big deal. You can train these, the doctors, and we can get that thing. But then we don't have offices that are equipped to do this kind of minor surgical procedure there. So that is a big issue. Even if the Probify, the marketers, the applicant, the ones who want to bring in Probify, they are saying that they will train the doctors, but then they can give us all the training, but you won't have the office which is, set for this level of surgical implant. And also with this kind of implant, we want to make sure that you implanted 4 of those, and you have, and the implantation and the removal is a huge procedure for that. So if you make a mistake, then there's bleeding and hematoma. And also the worst thing is if the implant is kind of moved away or kind of propulsed, and you need to send the patient to get an MRI. And that means you should be attached to an MRI center. And if that's not feasible, then it's going to be a problem. And looking at that, that means you're going to have 2, specialists working hand in glove, meaning one with the surgical minor surgical licensing. So those kind of healthcare professionals will be implanting and removing the thing under the supervision of the prescriber, meaning the ones who don't have this expertise or the special, the office which is ready for them to be able to put the implant and remove it. So then now you're talking about 2 people, working collaboratively.
Yes.
That is a big question mark. Is that doable, So that in itself is a big problem.
Now, in closing, Dr. Cidambi, where can we get more information on the web about your therapy and the Center for Network Therapy?
It is on the web. It is recovery, recoverycnt.com. So it's Center for Network Therapy. And we also have a Facebook. And they get all information through our center. And they can call 732-560-1080. We are open 7 days a week, and there will be an answering service after hours, and we will be able to return their calls. And there is no waiting period for patients to get in for treatment.
Thank you so much. You've been listening to Health Professional Radio. I'm your host, Neal Howard. We've been in studio this afternoon talking with Dr. Indra Cidambi, leading addiction expert and medical director at New Jersey's first licensed outpatient substance abuse detox facility known as the Center for Network Therapy. She has more than a decade of experience in addiction medicine, has in-depth knowledge and vast experience in addictive substances, treatment, and rehabilitation. It's been great having you here with us today, Dr. Cidambi.
Thank you. Thank you very much.
Transcripts and audio of this program are available at hpr.fm, and you can subscribe to our podcast on iTunes.